We just have to wait for the circle of death to stop spinning, and then there we go. We're live. Hello, everybody. Thank you so much for joining for the sort of penultimate session in a sort of short revamp of the Neurology Series. We're still sort of planning on where we go from here with it. Basically, if you have any bright ideas, please feel free to email us. Tonight, Dr. Amit Chowdhury, who's another neurology registrar from University Hospitals Plymouth in the southwest of England, is going to talk about everything we need to know about Parkinson's disease at sort of F1 and SHO level. So without any further ado, I'll hand over to you, Amit.
Thank you, Alex. Hello again, everybody. My name is Amit Chowdhury. As Alex has said, I'm one of the neurology registrars based in Plymouth. I will try to give you a basic idea about Parkinsonism, Parkinson's disease, and relevant question. I'm not sure whether it will cover everything you need to know. I have tried to keep it very basic because as my understanding is, it is the target audience is here mostly foundation level doctors and very junior SHOs. So the talk is probably very basic for you, but feel free to ask a question. I will try to address the question at the end of the session if within my capacity. All right, so let's start. But before we go further ahead, can I please ask you to join at vvox.app in your mobile phone or in your computer or whatever, and use this ID to please log in. I will use this interface to do a little bit of communication with you guys. I will give you a few seconds, maybe 20 to 30 seconds to join before we go ahead. So vvox.app, if you could type it in your address bar and use this ID to shown in the screen to log in. Alternatively, you can scan the QR code here on the screen. All right, let's go ahead. So aims and objectives of this talk is going to be give you a very basic idea about your understanding about Parkinsonism, causes of Parkinsonism. And we all know the commonest cause of Parkinsonism is Parkinson's disease. We will have a very idea about the very basics of clinical feature, investigation, treatment, and complications of Parkinson's disease. Now, first thing first, Parkinsonism. Please focus that I'm not talking about Parkinson's disease, it's Parkinsonism instead. What does it mean? Parkinsonism is actually an umbrella term to describe a group of conditions which present with these cluster of symptoms shown in the screen. These are mostly basal ganglia. These are actually more basal ganglia related functions. So group of syndrome, group of conditions present with basal ganglia abnormality, basal ganglia functional abnormality is called Parkinsonism. And what are these symptoms? These are these four shown in the screen: tremor, rigidity, bradykinesia, and postural instability. All these are very important. We will try to describe all these individually in next few minutes, but it's important to keep these four things in mind. These are actually part of diagnostic criteria in all the conditions. So tremor, rigidity, bradykinesia, and postural instability. I'm repeating it so that it registers in your brain and don't forget, so that you can keep it in mind when you see the next patient. Now, about causes of Parkinsonism, there are primary and secondary causes. As you understand, primary cause means the disease or the condition itself is responsible for the presentation, and secondary cause means something else affected the basal ganglia. That's how the symptoms of Parkinsonism came in. Now, the first screen here shows causes of primary Parkinsonism, and we divide the causes of primary Parkinsonism into two groups. One is Parkinson's disease or idiopathic Parkinson's disease. In this talk, I will use Parkinson's disease instead. And when I say Parkinson's disease, I will mean idiopathic Parkinson's disease. And another group is Parkinson's plus disorders. There are few entities in the Parkinson's plus disorder, as it shows in the screen. These are progressive supranuclear palsy, corticobasal degeneration, multisystem atrophy, and Lewy body dementia. We will not focus on the Parkinson's plus disorder today because it will be difficult to cover in one session. But to give an idea, just to get a general idea, is what is not. We will learn about the typical features of Parkinsonism in next few slides. What is if there is a patient of Parkinsonism, but it is not fulfilling the typical criteria of Parkinsonism, then you need to ask question about is it Parkinson's plus disorder or secondary causes. If we find any secondary causes causing Parkinson's syndrome, then we know that this is what causes Parkinson's syndrome. And if we do not find anything, then we need to think of primary causes other than Parkinson's disease, that is Parkinson's plus disorders. Now, the commonest causes of secondary syndrome is vascular Parkinsonism, normal pressure hydrocephalus, drug-induced Parkinsonism, toxin-induced, infective causes, and brain tumor. All these causes, individual causes, has their own kind of clinical features and specific characteristics. Probably it's difficult to cover everything here, but just to give you an idea, vascular causes of Parkinsonism happens mostly because if there is any multiple vascular lesions around the basal ganglia, so someone who has many vascular risk factors, we need to think of vascular causes. And characteristically, vascular Parkinsonism mostly involves the lower limb. Normal pressure hydrocephalus has a specific triad of symptoms. We use the term acronym GUM. So it's G for gait, U for urinary incontinence, and M for memory problem. Commonest drug which can cause Parkinsonism is antipsychotic and antiemetic. Toxin, we don't see this much recently, but some old type of insecticide is called MPTP or something like this. Not much used these days. These was shown a quite significant relation with Parkinsonism. Any intracranial tumor around the basal ganglia can cause similar features. Now let's focus into Parkinson's disease itself. As I mentioned, it's idiopathic primary Parkinsonism. This is the second common neurodegenerative disorder. Any idea about what could be the commonest neurodegenerative disorder? It's Alzheimer's disease. And there was 6.1 million there is a huge group of patients throughout the world. Now, among the Parkinson's disease patients, 10 to 15% only have a genetic background. There are 7 or 8 genes identified. I have shown these genes in my in this slide. Probably there is no point in trying to memorize these things, but just keep in mind that 10 to 15% can have genetic background. Some of these genes are autosomal dominant, some are recessive, so there is no specific pattern. And some of the genetic Parkinsonism starts early, but not all of them. So it's difficult to predict that it could be genetic or not. But probably it's just good to know that this LRRK2, this is the commonest cause of genetic Parkinsonism throughout the world, and this is an autosomal dominant one. And in this situation, in this genetic LRRK2 related Parkinsonism, it starts a bit early than the usual onset of age. The median onset of age of Parkinsonism is something like 60 or 61. In case of LRRK2, it's slightly less than that. So how it happens? Just a very basic idea. It's when Parkinsonism happens only when there is atrophy of dopaminergic cell in the substantia nigra and not otherwise explained. And if you look into the into the cells in microscope, we can see alpha synuclein in Lewy bodies in microscopy. Please, this is something to be noted that by the time a patient shows the first features of Parkinsonism, at least 60%, maybe more, of the dopaminergic neuron in basal ganglia is already lost. Before that, the clinical feature doesn't appear. Now, the clinical features. We divide the clinical features into motor and non-motor symptoms. with time, non-motor symptom is getting more and more attention and importance. There are reasons. We will try to discuss it later on. Now focus on the motor symptoms first. Again, I am repeating these 4 things: bradykinesia rigidity, resting tremor, and postural reflex abnormality, that is postural instability. These are the 4 things. So just to get a little bit of idea, sorry, what is it? Oh, sorry, a bit of technical issues. All right, so just to get a little bit of idea about what is your understanding about this, about what could be the most important feature of in diagnosing Parkinsonism among these 4. If you could kindly go to that app and use this ID to join, and you can enter a poll. The poll is now open. I will give you some time to respond to this poll, if possible.
Amit, just while the poll's going on, we just have a question from Leonidas in the chat about causes. Is it D1 or D2 dopaminergics?
There is actually an imbalance between positive and negative circuits. So I don't exactly remember. D1 and D2. One is excitatory circuit and one is inhibitory circuit. It's because of imbalance between these 2. So I didn't. Probably it's as a clinician, it's not very. I mean, doesn't mean a lot to differentiate between these. But I don't remember actually. But as I remember, is imbalance between the excitatory and inhibitory circuit. Either D1 is probably, if I'm recalling right, D1 is excitatory and D2 is inhibitory circuit. So yeah, let's. I'm waiting because I can see a few other people has logged in and trying to vote. Let's close the. Oh, a few more votes are coming. So let's close the voting poll now. Let's see how it goes. Well, so the divided opinion. So tremor, bradykinesia, rigid. So the majority goes for tremor and bradykinesia. That's not very surprising actually, because when we think of Parkinsonism, probably tremor comes into most of our mind, but bradykinesia is actually the correct answer. Bradykinesia is essential. It's the only mandatory part in diagnosing Parkinson's disease. So this should be the right answer. And if you this is the diagnostic criteria. It's called brain bank diagnostic criteria. It is a bit old, but in NICE guideline in the UK, we still are using this criteria, but there is the NICE guideline was updated for the last time in 2017, but in 2018 there are a few updated guideline has come, but to my knowledge, our guideline hasn't adopted the new criteria. So we are sticking with the previous brain bank criteria. And if you could see on the top left corner box that you need bradykinesia as a mandatory part in the mandatory thing in diagnosis, and you need one among other 3. So these are the basic things, and there are supporting criteria for Parkinsonism and atypical features. So we need to make sure there are no atypical features, and supporting criteria. You don't need all of these. It just supports your diagnosis. So please focus. So here, Parkinsonism. So Parkinsonism usually starts on one side. It progresses, but it remains asymmetrical at least until late stage. In later stage, it can be symmetrical, but it starts in one side. It can progress in both sides, but it usually remains more one side remains more effective than the other. The tremor is mostly present in rest. There are a few situations where you can get action postural tremor as well. You will see it's called re-emergent tremor. Probably will not go that route, but there are mostly resting tremor, but other tremors are not. Other form of tremor can also be seen. Characteristically, Parkinson's disease responds very well to levodopa. in clinical situation, in clinical context, when we are not very sure between Parkinson's disease and Parkinson's plus, if you can recall, we are talking about, we sometimes use this as one of the point to differentiate. If the patient responds to levodopa, then it's probably Parkinsonism. It's very likely to be Parkinson's disease. It's called a levodopa trial. We will talk about the atypical features in the next slide, which actually are red. It's called red flag, because if we see these features, this is probably we need to ask ourselves again whether really it is Parkinsonism or not. So this is a bit of busy slide. I'm sorry, but we need to go through this. It's important to differentiate between Parkinson's disease and something else. So again, the first thing is bilateral symmetrical disease onset. It is the red flag. We know that Parkinson's disease is usually starts unilaterally and remains asymmetric at least until late stage. Rapid progression. Parkinson's disease progresses. That's very true. It needs to progress. If it doesn't progress throughout time, then it is probably not Parkinson's disease. What we see commonly in clinical practice, that if it doesn't progress commonly, then the possibilities actually are essential tremor or dystonic tremor rather than anything else. But if it progresses very rapidly, then again is a point of concern. So how to differentiate, how to measure what should be the speed? A rough estimation is if a patient becomes wheelchair bound within 5 years, it is probably something else. When we say something else, then I meant actually Parkinson's disease, Parkinson's plus condition. Mostly in this situation is PSP. Patient becomes wheelchair bound quite early in the stage. Just remember, PSP means progressive supranuclear palsy. Recurrent fall, again, PSP is one of the reasons stage, but severe autonomic failure is again more common in multi-system atrophy. You can definitely will see some sort of autonomic involvement, but with Parkinson's disease, but it starts mild symptoms and can become severe at late stage. Absence of non-motor symptoms. Yes, as I was saying, non-motor symptoms are getting more and more attention. Absence of non-motor syndrome actually gives us an idea that actually it could be something else, like essential tremor. Unexplained pyramidal sign. You will see unexplained pyramidal sign in secondary causes of Parkinsonism and multi-system atrophy, these kind of things. Now let's talk about the first thing, tremor. As we have already said, this resting tremor is the commonest and the earliest feature. I have in movement disorder, actually it's best to have an eye estimation how it looks like. If it doesn't matter how much you read the description of a tremor or how much I try to explain, it doesn't leave a long-term impact. But if you see how it looks like, then next time you see, you will know it immediately. So this is the picture, the shown, and I'm not sure whether you can see it in the picture in the slide, is a characteristic pill rolling tremor of the left thumb. And in most cases, this is one of the earliest symptoms, earliest presentation. This tremor, as common in most commonly starts in the arm, in the hand, but you can see it in somewhere else, in leg, jaw, lips, tongue, etc. Next feature is rigidity. As we all know, rigidity means increased resistance to passive movement, and so that means if you're ask the patient to just relax and be floppy, and then do the movement by yourself. Mostly we do circumferential movement of the wrist. You will feel a resistance is there. Cogwheel phenomenon is specifically described. Cogwheel phenomenon is a feeling when somebody feels it. The hand is being moved against a cogwheel. It's difficult to describe. But it's very easy to pick up once you have seen one. Cogwheel phenomenon is actually a result of tremor superimposed on rigidity. So there will be increased resistance, but there will be a little gap in between. So this, I don't know how much this picture helps to understand. Bradykinesia, as we have mentioned, this is the most important feature of Parkinsonism, and most of the features, motor features of Parkinsonism can actually be explained by bradykinesia, not all definitely. So bradykinesia means, brady means slow, kinesia means movement, so slowness in movement. Reduction, so we need to keep in mind that it's not just all about the speed. Speed is definitely important, but amplitude is also reduced here. And when we are examining, we need to examine all limbs separately, left, right arm, and left, right upper and the lower limb. And to give you an idea how we examine and interpret bradykinesia finding, I have a video extracted from YouTube. Hopefully you will be able to see. Let's try to. Oh. So if you can see the right side, there is the amplitude of the movement in the left or right side is massively different, and this, yeah, it is actually not very slow here in this specific situation. This specific case, it is a bit fast, which has a festinate type of component is there. So what we need to do with alternating movements. So the commonest and the most popular way to examine in neurology or neurology clinic is to actually at finger tapping. What you do like this, and for the lower limb, we ask the patient to tap on the floor, how fast they can tap. Let's go to the next one. Postural instability is that, well, the name explains itself. It's difficulty in maintaining a posture and stabilizing activity in walking, standing, turning, etc. Patient finds it most difficult to maintain stability in turning and when they're going through a narrow door. That's why sometimes patient can come with fall. But as we have already discussed, that we don't see fall frequently in early stage of Parkinsonism. If we do, then we need to question whether actually it is Parkinsonism or Parkinson's plus. Posture and gait. This picture shows actually a typical Parkinson's gait with forward tilt for a bit of flexed posture, and there is rigid. You will say rigidity and trembling of the head. I have a better video to describe. Probably it's quite popular. I have seen this in so many places in this video. So this gentleman has shown this Parkinson's gait probably the best way I have seen in free accessible media. I will play this media. Hopefully you will be able to listen and get a visual impression how the Parkinson's gait look like.
This gait is the gait.
Just let me check. Alex, can you hear the video can you hear the audio from the video?
Yes, we can.
That is a hypokinetic gait. The prototype is Parkinson's or Parkinsonian type of gait, in which the patient will have a posture which will be stooped over, leaning forward, and then will have difficulty as far as initiating gait. When the gait is initiated, there are small steps. Oftentimes there's a tremor associated with this. And as the gait progresses, there may be a picking up of speed, or what's called a fenestrated gait. And then in turning, instead of having the normal turning, the patient will turn en bloc, which means they'll turn almost as a statue moving around. And then again having difficulty starting in the marche petit pas.
Thank you. So gait is probably one of the most helpful clinical feature by which we diagnose a Parkinson's patient. Most of the times, there are exceptional situations, but most of the time we are most of us are able to diagnose the patient when the patient comes into our just enters the room. If as a routine part of Parkinson's disease examination, we take the patient for a longer walk, like 20 or 30 meters. I'm not ever, there is no specific guideline that it should be 20 meters or 30 meters, but we usually take a patient for a longer walk through the corridor when the question of Parkinsonism comes in. Speech, voice, swallowing. Speech is usually low volume, monotonic. The reason is again bradykinesia mostly in the vocal cord and the articulating muscles in the mouth. So that explains the low volume monotonic speech, difficulty in articulation. Again, bradykinesia is behind everything. Dysphagia, difficulty in swallowing. Again, lack of coordination and slowness of the muscles in the pharynx. Drooling and siluria. There are probably two reasons here for drooling and siluria. First is we all know that around 1.5, we all produce 1.5 liter of saliva every day. But since the swallowing is not very effective, there are excessive saliva always in the mouth, so that can cause drooling. And also because of autonomic abnormality associated with Parkinsonism, the production of the saliva might be increased. Those are the two reasons for siluria. Fine motor function, micrographia. We ask the patient usually to write something on not just once. It needs to be write 3 to 5 times consecutively. So, and you can compare when he started the writing and when he finished. Decreased manual dexterity. So this is the thing. This is the part where the patient's activity of daily living might be compromised, and so this is important to pick it up. Hypomimia, lack of blinking. Well, again, we can see bradykinesia is behind everything. Lack of blinking and hypomimia means expressionless face. So previously, historically, we used to use a word called expressionless face or something, but now sometimes people might find it often a bit of uncomfortable with the term, so we use a medical jargon, mostly hypomimia, to describe expressionless face. Non-motor symptom, we mostly classify in 3 or 4 groups: cognitive and autonomic, cognitive autonomic sleep problem, and olfactory. Cognitive, probably one of the most important part of the Parkinsonism. Depression, dementia, hallucination are the top 3 causes. Autonomic symptoms include constipation, urinary problems, erectile dysfunction, and excessive sweating. REM sleep behavior disorder is again quite common with excessive daytime sleepiness. I will not go into discussing the REM sleep disorder in detail today. A massive fraction of the patient, I forgot the number, olfactory problem, patient doesn't get a smell. The olfactory impairment is seen in Parkinson's disease, and some of the studies shows that olfactory impairment can appear a few years, 5 years or 10 years before, 5 or 7 years even before the onset of Parkinsonism. I don't know the explanation, to be honest. Now, again, investigation. So, delete the clear. So, investigation, again, to get your understanding, your idea. What is the best investigation you need to do? What's the investigation you need to do to diagnose a Parkinson's disease? Let's see what is your idea.
Amit, just got a couple of questions while people are responding.
Yeah, sure.
There's one from Leonidas again, who clearly is going through the rigmarole of preclinical side of things. So does the disease start with ipsilateral or contralateral symptoms? I think is what he's trying to say, including cerebral hemispheres and the first limbs that are affected.
So it starts with characteristically unilaterally. So if ipsilateral. So you mean so if the when the neurons, the basal ganglia cells, when they starts to atrophy, it is usually bilateral. It's always bilateral, but one side is always above, one side is always more advanced in one side. So what happens? We will always see if we do, if we are able to do autopsy or different some sort of, especially that like a DET scan or a SPECT scan, it can show that substantia nigra cells are more affected in one side, and if it is more affected in the left side, it causes more Parkinsonism in the right side. So I believe contralateral involvement is the answer he was looking for. What is the other question?
If the patient develops non-motor symptoms such as dementia, does that then become Parkinson's plus? Which is
that's an interesting thing actually. So the commonest cause of is it depression or is it depression or cognitive dementia? Dementia.
Cognitive.
Right. Yeah. So no. The reason dementia is more important is actually to differentiate with some other symptoms. Specifically, else we will see Alzheimer's on the top of that. So Alzheimer's is the question if a depression, if dementia comes in. So we can have dementia in Parkinson's disease itself. It's called PD dementia. And you can have dementia due to Alzheimer's itself, because it's all neurodegenerative condition. They can come together. So the way to differentiate is if the dementia comes within one or two, within early in the Parkinson's disease, especially within 1 or 2 years, then it's not due to Parkinson's. It's due to Alzheimer's disease at the same time, because dementia exclusively due to Parkinson's disease come in the late stage. Well, now let's go back to the poll. DET scan and none of the above are the majority. So actually the right answer is none of the above. The reason is Parkinsonism is a very clinical diagnosis. You don't need to do any investigation at all to diagnose. We arrange the investigation if we are in doubt to exclude other causes, exclude any alternate diagnosis. Parkinson's disease is very, very clinical diagnosis. This is written so many times because I wanted to take it as a take-home message that you don't need to do any investigation. It's very clinical diagnosis. So the role of investigations is actually for ancillary purposes, just to support your diagnosis and exclude other causes. The commonest thing we do is MRI, and if you can remember, we are talking about the secondary causes of Parkinsonism. MRI actually looks for mostly in the secondary causes. Every secondary cause, most of the secondary cause has its own kind of presentation, like normal pressure hydrocephalus, iron deposition, infarct. I will not discuss it as a routine, but if we get time after the webinar, then we can definitely discuss about the MRI finding of the alternate causes. Very popular is DET scan. It is actually as a form of SPECT scan when you use radioactive iodine. What it shows, it actually shows the dopaminergic loss of dopaminergic terminal. So what it means, the cells are actually in substantia nigra in the midbrain, but the terminal is here. The axon ends somewhere in some places in the basal ganglia, and you will see in a normal person, if you can focus on the left side, there are two commas. It should be a comma-shaped thing. Where's my mouse pointer? Yeah. So if you can see, there are two comma-shaped things. So this is the normal one, and on the one on the right side, if you can see that the comma there is no more comma anymore. There is just a circle, but we have that bit is lost. And as we can see that there is asymmetric there is involvement bilaterally, but slightly asymmetric, which we see in Parkinson's disease. Here the left side is more affected, so this gentleman will have more Parkinsonism will be more evident, more clear, more obvious on the right side. Treatment. We can divide it into pharmacological and non-pharmacological treatment. Non-pharmacological treatment is very important, and probably is equally important than to pharmacological treatment. What we need to do is occupational therapy, physiotherapy, SALT review, and regular exercise, physical activity. We will, as a clinician, let's focus on the pharmacological treatment. These are the class of drugs. It's probably not possible to go in details with all the drugs, but in brief, the group of drugs are dopamine agonist, levodopa, MAO-B inhibitor, COMT inhibitor, amantadine, and anticholinergic. We will try to discuss in a very brief level regarding about the medicines. Again, let's start a poll where, just to get an idea of what you think. Like, let's assume a 75-year-old man. It's a very made-up case. 75-year-old man who have come with very Parkinson, typical features of Parkinson, tremor, rigidity, bradykinesia, unilateral, one side, and his ADL is affected. So you need to start some sort of treatment. Let's assume that it is a proper Parkinson's. Clinically, the diagnosis is Parkinson's disease. What is the treatment? Is it? Oh no, it's probably something, I don't know. Oh, probably it's all right. So it's probably already exposed. That is fine. So the question is actually, what's the best treatment we should start here? The answer is, I will give the answer here is levodopa, carbidopa should be the first thing. The reason, what the explanation of the reason is, lies in the NICE guideline. The NICE guideline 2017 says, when motor symptom impact the quality of life, levodopa should be started. And when we have the diagnosis, but activity of daily living is, or quality of life is not compromised yet, we have three options: dopamine agonist, levodopa, and MAO-B inhibitor. The reason for this differentiation is levodopa is much more effective with less significant side effect profile than the other options. Then if the patient doesn't have the activity of daily living is not affected, then why we need to consider other options? The reason is the efficacy of levodopa reduces quite rapidly with time, and it comes with more and more side effects. So levodopa roughly works for between 5 to 10 years or something. It's not don't take it. Accurate. It's not an accurate impact. It's just a rough idea. So more than that, it doesn't work. It comes with more complication and side effect. But the other options, they might be less effective, but the side effect profile is not very evident. That they all have their own side effect, but less intense than late stage levodopa treatment. We will go into that. The first, levodopa. Levodopa, as we all know, levodopa is the active drug. It always comes with dopa decarboxylase inhibitor, that is carbidopa or benserazide. If it is combined with carbidopa, it's called in UK we call it co-careldopa. If it is combined with benserazide, we call it medopa. The idea is, how you start, you should try to find the lowest effective dose, the lowest dose which gives symptom relief, so that the patient can continue activity of daily living. Jumping with the dose quite fast and is not ideal. We were talking about a side effect of levodopa. The commonest one is, the most important one is dyskinesia, and it is seen in 40% patients after 4 years. So as you can imagine, so it is a massive number just after 4 years, so 40% patient. And after appearance of dyskinesia, after 1 or 2 more years, it becomes really difficult to continue levodopa at all. We can see dyskinesia. We can divide the dyskinesia into peak dose dyskinesia and diphasic dyskinesia, which I will try to explain in this slide here. Before going to the individual discussion, let's have an idea about how a dyskinesia looks like. Again, in movement disorder, visual impression is very important. So that's what dyskinesia looks like. It can
I said that on that he is from Turkey and Melchizedek. Oh, so do you know why? Because I've been in Indonesia and I know Muslim, that's why I kind of noticed that. I know Turkey. Do you know Turkish and that Muslim? Do you know that?
No.
okay. So this individual case actually for something, the diagnosis is not Parkinson's here, but it looks the same. Now it's important to keep in mind that it's not always will affect that Parkinson's affected side or unilateral. It can be most of the times it's actually bilateral. So now if we can focus into the graph there, the chart there on the top right side, it shows a graph of blood level in plasma concentration of levodopa. So this gentleman takes the medicine 3 times a day. So if the dyskinesia appears on here when the blood level of the levodopa is highest, it's called peak dose dyskinesia. If it appears here, so that means either end of the previous dose or just before the next dose. It's called diphasic dyskinesia because it can cause the dyskinesia comes in when the blood level drops twice, before and after, immediately after taking levodopa. This one, that the below the right, the below this chart shows a bit of idea about risk of dyskinesia and clinical symptoms. So if we look into the left, when we start, usually a very good response is there, but with time the window of good response reduces and there are more chances of dyskinesia and more chances of inadequate response. Let's go to the next slide. When we talk about big dose dyskinesia and end of dose dyskinesia, you will also hear the term wearing off effect. Wearing off effect means the efficacy of levodopa gets reduced or compromised eventually with time. So here again, this chart shows that this gentleman takes levodopa 3 times a day. So this is a rough blood level here. So if initially the patient will remain symptom free or less symptom here when the blood concentration is here, but with time this wearing this period, the patient will be more and more symptomatic during this phase. So we will see that the patient was symptom free when levodopa was started, just before taking the dose, taking the tablet, but with time this window increases more and more, and patient becomes more and more symptomatic just before taking the next dose. It is called wearing off effect. Now, how to manage this? The answer is it's difficult to manage, is the straight answer, but sometimes there are some reversible things we can do. If we see the wearing off effect of more and more off phenomena. Off phenomena means when the Parkinson's is not controlled well with levodopa. The first thing we need to look for is constipation. Believe me that this is probably one of the commonest cause that we can see in a Parkinson's patients, because constipation affects absorption. And the second thing is if the patient is taking the medicine in the right way. Levodopa should be taken 30 minutes after the previous meal or 1 hour before the next meal. Otherwise, protein content in your meal can affect the absorption of levodopa. If we manage, we made sure that absorption is correct, then we need to adjust the dose timing. The thing is, we need to make it more frequent. If patient was getting it 3 times a day, we may need to plan for getting it 3 times a day. The next step in managing off phenomenon is to add something else on the top of the 3 or 4 times a day levodopa. The commonest choice is most of the times COMT inhibitor. We can see it's sold as entacapone. It's one of the trade names here. Dopamine agonist. These are just some name of dopamine agonists. Different medicine. Different medicine comes in different formulation. Like rotigotine comes in patch. Ropinirole comes in tablet. Apomorphine comes in mostly in injection forms. In different situation, we use this. Commonest one of the commonest thing, commonest situation when we need to use patch is when patient is not able to eat or drink. So, for example, if a patient is going for a surgery, is remaining nothing by mouth for a certain period of time, we cannot stop Parkinson's treatment because it can cause more massive some serious complications like akinetic mutism kind of stuff. So it's important to continue the medicines when in alternate form. So rotigotine is our choice there. So there are some online calculators. If you input what kind of medicine the patient is on and what form, it will give you the dose of rotigotine. It's called optimal calculator, as I can recall. So you can try Googling optimal calculator and can get the dose. So when we receive a call about when you're on call neurology registrar about this is the situation, we cannot continue oral medicines. What we can do, we just go to that calculator by ourselves while we are talking and then give you an idea. Tablets are used if we are using dopamine agonist at the beginning of the condition. Then ropinirole is the one of the commonest choices here. Apomorphine is injection are used for complicated Parkinson's patient when they have freezing episodes and this stuff. So the side effect of dopamine agonist and levodopa, they have more or less the same side effect profile, except this impulse control thing. But nausea, orthostatic hypotension, and sleepiness is quite common in both levodopa and dopamine agonist. This impulse control is an interesting one. It's more seen in dopamine agonist, and sometimes it can be so intense that can affect significant daily life significantly. Like, for example, I know of a patient who has spent their lifetime saving to buy a Mercedes. It's called Wagon F or Wagon G, something like a very expensive one. I don't have any idea. So he bought this out of impulse, and then he needed a letter from us that it can be a drug of it can be related to drug side effect. The commonest impulse we can see is the usual, and so we can see is in gambling, excessive unexplained shopping, binge eating, binge drinking, hypersexuality, etc. If not all the time, if we have a little sign of excessive impulse control disorder, it's not like that we need to reduce the dose of dopamine right away. But if it is affecting daily activities, how much the patient is bothered, then we need to think of reducing the dose of dopamine agonist. But as you can understand, it will come in the cost of losing control over the Parkinson's symptom itself. Other treatment options, amantadine is as an NMDA receptor agonist, which is probably not used in the UK anymore. MAOB, MAOB is the commonest inhibitor. Commonest example is selagelin in the UK. There are few studies historically they questioned that selagelin might have disease-modifying effect, that like it slows down losing dopaminergic cell, but further studies couldn't confirm it. So that idea is excluded now. So now at the moment there is no disease-modifying drug at all for Parkinsonism. But in some old papers, you might see that selagelin might have disease-modifying effect. COMT inhibitor, entacapone, is the commonest example and is almost in the UK. It's almost exclusively used in adjunct therapy when we find it difficult to control symptom with dopaminergic drugs. Anticholinergics are the first rule I should say is never use anticholinergic for treat Parkinson's disease. It's only used, is more effective in, it only affects some tremor. As you can say, the tremor is not the most disabling symptom in Parkinsonism. It's rather bradykinesia is. So managing anticholinergic is helpful only if you can see drug-induced tremor. This only in this situation, anticholinergic is helpful, but I'd say that we need to think twice, maybe more, if we want to use anticholinergic in an elderly patient, because it's most of the patients find it very difficult to tolerate, and you will see confusion quite immediately after starting anticholinergic, especially if it is in high dose. Other side effect, as you can imagine, the autonomic side effect, including dry mouth, constipation, and urinary retention. Recent treatments, I will just say the names, like deep brain stimulation, dopamine, apomorphine pump, which you use for off phases in Parkinsonism. Off phase patient is fine, suddenly gets freezed out of nowhere. It's very difficult to control situation, but apomorphine injection shows some efficacy. And levodopa carbidopa intestinal gel is a new addition. It's the same thing, but just they use a device and there is and deliver the drug directly to the intestine through a hole, through a stoma on the tummy, and it just it's just more helpful in maintaining a persistent level of levodopa in the blood rather than carbs. Again, just a quick question, just to give some idea. So I showed you a DAT scan before, just to get a bit of recap that what you understand. There are 3 DAT scans showed here. Which one you think could be Parkinson's, idiopathic Parkinson's disease? Let's open the poll, see how it goes. I'm waiting because I've seen some people logged in, but still waiting to vote. Well, let's close the voting window here. Yeah, good. So many people are for image 3. To be honest, both 2 and 3 could be seen, but if you could focus a little bit, you can see that it is the asymmetry is more in the image 2, and the dopaminergic cells are lost, but looks more or less symmetrical. So you cannot say in C it is possible, but if you have to choose one, the best answer would be probably 2, because if you can still remember, we are talking about a comma. If you can see, I'm not sure whether you can see my mouse pointer, that there is a proper comma shaped thing here, but in the left side, in the second picture, you cannot see that bit of the comma anymore. So it's significant asymmetry will probably keep number B as a better option for idiopathic Parkinson's disease. You will see option C in more commonly with Parkinson's plus, which can be asymmetric. If you could quickly recall that we are talking about red flag signs, that symmetric involvement is one of the red flag, and you will see symmetric involvement in Parkinson's plus rather than idiopathic Parkinson's disease. Probably I am at the end of the session. So yeah, thank you for your time and listening. I would try to answer questions if you have any. Alex, do you have any question?
I can't see any more that have come through. I've just sent the feedback out.
Thank you.
We had 61 people in the end, which is very good.
No, that's impressive. Yeah,
it's testament to to you, Amit, I think. But
right. Let me see if I can see in my chat box anything. Thank you.
I think we covered whatever questions people had throughout. We covered.
Well, some of the people tried to answer the votes through here. I'm sorry I missed that. Same or different? I didn't understand. So Leonidas was asking something similar.
Yeah, I think he sort of asked. Basically, he said unilateral instead of ipsilateral, and then he wanted to know if it's unilateral or bilateral, as well as if it's ipsilateral or contralateral. So 2 separate questions.
Well, yeah. So hopefully we have touched it.
There's a new challenging one for you. Can you please tell us about disease-modifying therapies and biomarkers?
In Parkinson's disease, to my knowledge, there is no disease-modifying therapy till date which is proved beyond doubt. Biomarkers, I am not very sure, to be honest. I can see there is from AB, there is biomarkers in PD, including advanced genetics. In the UK, we can say that we don't do genetics test as a routine. Only we do it if there is any obvious family history, or mostly for research purpose. For clinical purpose, I'm a clinician, so clinical purpose we don't do it as a routine. And I just know about the glucocerebrosidase GB1 and LRRPK2. I just know the name, to be honest. I don't know any further detail about these biomarkers, to be honest.
I'm reaching back into the depths of my clinical neuroscience MSc there, and I'm struggling to find anything.
Yeah, I just know the names. I don't know any further biomarker and detail about these individual genetic types. But only 10 to 15% are genetic, and from clinical point of view, diagnosing in genetics will not change any management plan or anything. So that's probably the reason we don't do routinely genetic condition. I don't remember actually referring any patient at all for genetic tests for Parkinsonism. Maybe it's my experience, but I don't remember any patient sending a patient at all. For research purpose, it will be completely different, but for clinical purpose, it's probably doesn't add much to the plan. Anything else?
I can't see anything. We get the odds. Oh, Addy's posted a paper.
Right, yeah, that's
future of targeted gene-based treatment strategies and biomarkers. There we go. There's some.
Right. To be honest, Abby, I don't have much idea, but I will definitely try to. I will go through the paper you have kindly forwarded. Yeah, we'll go into it. I don't know is the answer.
Like I say, as I said at the beginning, the aim of this talk is very much F1 and SHO level rather than.
Yeah, that's what my plan was.
What might we be able to treat in 50 to 100 years' time when we've got the short interfering RNA technology ready to go? Fine. Well, if that is everything, I am going to take us offline, I think.
All right. Thank you very much, everybody, for your time and kind listening.
Thanks very much, everybody. And how do if I leave?
Shall I leave?
You can leave. Yeah, I'm just going to see what happens. Can you please fix my name in the certificate? That is based on how you've spelt your own name on the system. So there's not much I can do about that, unfortunately.
So did you ask me anything? Sorry.
No, that's someone's posted in the chat.
All right. Yeah. All right. Okay.
So yes. Okay. I'm going to stop broadcasting now.
All right. Thank you very much.